Let me ask you something and answer honestly. If your hemoglobin dropped by 1 full point this month, would you even notice? Most people wouldn't, and that's exactly why low hemoglobin becomes dangerous before it becomes obvious. Last time we talked about what hemoglobin does, how it carries oxygen, how it keeps your organs alive and functioning. Today, we're not repeating any of that, because today's question is far more unsettling. Why does hemoglobin fall at all when the body works so hard to protect it? Think about it. Your body guards oxygen like a priority system. Heart, brain, lungs, everything depends on it. So when hemoglobin starts dropping, it's not random. It's a signal. A message that something, somewhere is going wrong. But here's the problem. Hemoglobin doesn't fall like a light switch. It falls like a leaking ceiling. One drop, then another. So slow that you adjust without realizing it. You wake up a little more tired, but you blame sleep. You feel breathless, but you blame stress. You lose focus, but you blame age, workload, responsibilities. This is exactly what happened with Nancy. Nothing dramatic, no hospital visit, no collapse. Just a slow decline that everyone ignored, including her. Until one day, a routine test showed a number no one expected, and that's when panic begins. Because once the number is low, the question changes from why to how bad is it. But panic isn't helpful. Understanding is, that's why this video exists. Because low hemoglobin is almost never a mystery if you know where to look. Over the next hour, we're going to connect the dots most people never do. We'll talk about when your blood doesn't have what it needs to be made. When blood is quietly leaving your body without obvious signs. When completely unrelated organs sabotage red blood cell production. And why two people with the same hemoglobin number can feel completely different. And no, this isn't about self-diagnosing or fixing things on your own. This is about understanding the system. Because when you understand the system, doctor visits become clearer, reports make sense, and fear loses its grip. By the end of this video, you won't just know what causes low hemoglobin. You'll understand which cause applies to whom and why. But we can't start with diseases or emergencies. We have to start with the most underestimated reason hemoglobin falls. The one people assume is simple, but almost never is. What happens when your blood is ready to work, but it doesn't have the raw materials to be built? That's where the real story begins. Most people think anemia starts with a disease or a sudden emergency, but in reality, low hemoglobin often begins much earlier, in the kitchen, in the gut, or inside silent deficiencies no one talks about. Your body makes red blood cells every single day. Millions of them, and for that it needs raw materials, not motivation, not willpower, actual biological ingredients. When even one of those ingredients is missing, the entire system slows down. Let's start with the most famous one, iron. Iron is not just a nutrient. It's the core material hemoglobin is built from. Think of hemoglobin like a delivery truck carrying oxygen. Iron is the engine. No engine? The truck doesn't move. This is where many people misunderstand iron deficiency. They think it means, I don't eat enough. But that's only one possibility. In Nancy's case, food was never the problem. She ate 3 meals a day. Vegetables, grains, even occasional meat. But her diet lacked absorbable iron, and that's the catch. There are 2 types of iron. Heme iron, easily absorbed, mostly from animal sources. Non-heme iron, plant-based, harder to absorb. Now add real life to the equation. Tea with meals. Coffee every morning, antacids, acid reflux medications. Gut inflammation. All of these quietly block iron absorption. So even when iron is present on the plate, it never reaches the blood. This is why iron deficiency anemia can take months or years to show up. It's not dramatic. It's cumulative. Now let's move to the second player that almost no one expects, vitamin B12. B12 doesn't build hemoglobin directly. Instead, it helps your bone marrow produce mature, functional red blood cells. Without B12, red blood cells grow abnormally large, break early, carry oxygen inefficiently. This is exactly what we saw in Rachel's case. Her hemoglobin was falling, but not in a predictable way. Iron supplements didn't help much. Diet changes didn't fix it because iron wasn't the main issue. Her B12 levels were critically low. And here's why B12 deficiency is so dangerous. Symptoms don't always match the numbers. Some people feel fine at first. Others develop brain fog, tingling in hands and feet, mood changes, long before severe anemia appears. Vegetarians and vegans are at higher risk, but they're not the only ones. Low stomach acid, autoimmune conditions, long-term metformin use, even aging, all of these interfere with B12 absorption. So again, this isn't about effort, it's about physiology. Now comes the third piece of the puzzle, folate. Folate works alongside B12. It helps cells divide properly. When folate is low, red blood cell production becomes chaotic. Cells form incorrectly. They die early. They never reach full efficiency. This deficiency hides easily because folate levels can drop due to pregnancy, chronic stress, alcohol use, certain medications, even people who eat healthy can run low. Here's the bigger picture most people miss. Iron, B12, and folate deficiencies don't happen in isolation. They overlap. They mask each other. And they confuse blood reports. That's why someone can have borderline, iron, low normal, B12, acceptable folate, and still have worsening hemoglobin. This is also why self-treatment fails. Taking iron blindly when B12 is low? Limited improvement. Correcting diet without absorption? No change. Ignoring lab patterns? Delayed diagnosis. And this brings us to an uncomfortable realization. If your body has the nutrients or even supplements, but hemoglobin is still falling, then the problem may not be what's missing. It may be what's leaving. And that's where the next chapter takes us. Because blood loss doesn't always look like bleeding. Lastly, we talked about what happens when your blood doesn't get what it needs. Iron, B12, folate. But now comes a harder truth. Sometimes your body has everything it needs to make blood, and yet hemoglobin still keeps falling. So where does it go? The answer is uncomfortable but important. Sometimes your blood isn't failing to form. It's leaving your body quietly. Let's start with the most common and most normalized cause of all. Menstrual blood loss. For millions of women, heavy periods are treated like a personality trait. She's always tired. She has painful cycles. That's just how her body is. But here's the medical reality. Excessive menstrual bleeding is not normal, even if it's common. And this is where Priya's story becomes painfully familiar. Her periods were long, sometimes 10 days. Sometimes unpredictable. She planned her life around them. Work, travel, social events. But no one ever connected those cycles to her blood reports. Month after month, iron was being lost faster than her body could replace it. And because the loss was gradual, the symptoms crept in slowly. Fatigue felt normal. Dizziness felt occasional. Shortness of breath felt like stress. Until one test revealed the truth. Her hemoglobin wasn't slightly low. It was critically low. Now let's talk about blood loss that scares people even more: gastrointestinal bleeding. This one is dangerous because it hides well. You don't see blood. You don't feel pain. You don't rush to a doctor. Tiny amounts of blood can leak into the digestive tract due to ulcers, gastritis, piles, intestinal inflammation, long-term painkiller use. Each day, the loss is small, but over weeks and months, it adds up. This is why doctors ask questions that feel strange or uncomfortable. Stool color, digestive habits, medication history. They're not being intrusive. They're following the trail of missing blood. Now consider surgical blood loss. After surgery, many patients hear, "Everything went well." And medically, that may be true. But blood loss during surgery, even controlled blood loss, still has consequences. Hemoglobin can drop significantly. If recovery nutrition is poor, if absorption is compromised, or if underlying deficiencies exist, the body struggles to rebuild what was lost. Here's the key realization most people miss. Blood loss doesn't have to be dramatic to be dangerous. No accidents, no visible bleeding, no emergency. Just a slow imbalance, loss exceeding production. And this creates a vicious cycle. Low hemoglobin causes fatigue. Fatigue reduces appetite. Poor intake worsens recovery. And the cycle continues. This is why supplements alone don't always work. If blood is leaking out faster than it's being replaced, no tablet can keep up. Now pause for a moment and connect the dots. Previously, we talked about missing ingredients. Now we talked about ongoing loss. But there's a third category, and this one surprises almost everyone. Sometimes hemoglobin falls even when nutrition is adequate and blood loss is minimal. Because the problem isn't in the blood at all. It's in other organs that quietly control blood production. And once those organs struggle, hemoglobin becomes collateral damage. That's where we're going next. Because to truly understand anemia, you have to stop thinking only about blood. You have to look at the whole body. Previously, we talked about two powerful forces that pull hemoglobin down, what your blood is missing, and what your body may be losing without you noticing. But there's another layer to this story. And this one feels almost unfair, because sometimes you can eat well. You can correct deficiencies, you can stop blood loss, and still, hemoglobin refuses to rise. That's when doctors start looking beyond the blood itself. Because red blood cells don't exist in isolation. They are controlled, supported, and regulated by other organs. And when those organs struggle, your blood quietly pays the price. Let's start with one of the most overlooked players, the kidneys. Most people think kidneys only deal with urine, filtering waste, balancing fluids. But kidneys also release a hormone called erythropoietin. This hormone tells your bone marrow, make more red blood cells. When kidneys are damaged, even mildly, that signal weakens. The bone marrow slows down. Red blood cell production drops. This is why people with chronic kidney disease often develop anemia even when iron levels look acceptable. No raw material problem, no blood loss, just a missing signal. Now let's move to the thyroid. The thyroid controls metabolism, how fast or slow your body runs. When thyroid function is low, everything slows down, including bone marrow activity. Red blood cells are produced more slowly. They circulate less efficiently. Hemoglobin numbers drift downward. This connection surprises many patients. They treat thyroid symptoms, weight gain, cold intolerance, hair loss, but no one explains why hemoglobin is also low, until both problems are seen as part of the same system. Now let's talk about chronic inflammation. This one is subtle and extremely common. Autoimmune conditions, long-term infections, even poorly controlled diabetes. Inflammation changes how your body handles iron. Iron may be present. Ferritin may even look normal or high, but the iron is locked away, unavailable for red blood cell production. Doctors call this anemia of chronic disease. Patients call it confusing because they're told, your iron isn't low, yet hemoglobin keeps falling. This is where many people lose trust in reports and start guessing or self-treating. Now remember Helen, 41, high-pressure job, living on coffee, skipping meals. She thought her fatigue was burnout. But her blood told a different story. Her anemia wasn't just about food choices. It was about absorption, stress, and long-term depletion. This is a pattern doctors see often, especially among vegetarians and vegans. Not because plant-based diets are bad, but because B12 availability becomes critical. According to NHS clinical reviews, B12 deficiency anemia is one of the most common hidden causes in adults who avoid animal products. Again, not a failure of discipline, a gap in physiology. Now step back and look at the pattern forming. So far, we've seen that hemoglobin can fall because the body lacks raw materials. Blood is being lost slowly, or other organs are disrupting production. This is why two people with the same hemoglobin number can feel completely different. One may feel exhausted at HB9. Another may walk around at HB6, because the cause matters more than the number. And here's where things often go wrong. When doctors or patients focus only on hemoglobin itself, they try to push the number up without asking why it fell. But hemoglobin is not the disease, it's the messenger. And ignoring the message leads to frustration, delay, and sometimes danger. Which brings us to the next critical question. If causes are this complex, nutritional, bleeding-related, organ-driven, how do doctors actually figure out what's happening inside a specific person? That answer lives inside blood tests. But not just one test, a pattern. And understanding that pattern changes everything. So far, we've seen that hemoglobin doesn't fall for just one reason. Sometimes the blood lacks raw materials. Sometimes blood is slipping away quietly. Sometimes other organs interfere with production. Low, borderline, or normal. And suddenly, everyone is guessing. But doctors aren't guessing. They're reading patterns. Because a single hemoglobin number doesn't tell the story. The story lives in the combination of tests. Let's start with the most common 1CBC, or complete blood count. This is usually the first test ordered. And for good reason. CBC doesn't just show hemoglobin. It shows how your red blood cells are behaving. Their size, their shape, their concentration. One value doctors look at closely is MCV, mean corpuscular volume. In simple terms, it tells whether red blood cells are smaller than normal, larger than normal, or about the right size. Small cells often point toward iron-related issues. Large cells raise suspicion for B12 or folate problems. Normal-sized cells shift attention toward chronic disease or blood loss. Hemoglobin is the delivery truck. You can have an empty warehouse and no trucks, or a full warehouse with trucks that aren't allowed to leave straightforward. But normal or high ferritin doesn't always mean iron is fine. Remember what we discussed earlier about inflammation? Ferritin rises during inflammation. It acts like an emergency lock. Iron is stored away and hidden from circulation. So a person with chronic illness may have low hemoglobin, normal ferritin, and still be iron restricted. This is where many people get confused. They're told your iron is okay, but hemoglobin doesn't improve. Now let's bring in iron studies. This usually includes serum iron, total iron binding capacity, TIBC, transferrin saturation. Low serum iron with high TIBC often points toward deficiency. Low serum iron with low TIBC suggests inflammation-driven anemia. Again, patterns, not isolated numbers. This is why doctors rarely rely on one test alone. Now think back to Rachel. Her iron supplements didn't help much at first, because the issue wasn't just iron intake. Her CBC showed large red blood cells. Her MCV was elevated. That clue pushed doctors to check B12. Once that was addressed, the entire picture changed. Now consider Helen's case again. Her initial tests looked mildly abnormal, nothing alarming. But the combination low B12, borderline hemoglobin, lifestyle stress told a different story. Without that broader view, her anemia would have been labeled as fatigue or burnout. This is also why timing matters. Blood tests are snapshots. They reflect what's happening right now. Recent illness, infection, or surgery can distort results temporarily. That's why doctors often repeat tests after a few weeks before making long-term decisions. Now let's talk about something patients often ask. Why didn't my doctor order all these tests at once? Because testing follows logic. Doctors start broad, then narrow. CBC first, then ferritin, then iron studies, then B12, folate, thyroid, kidney markers if needed. This approach avoids unnecessary testing and reduces confusion. But here's the most important takeaway. Blood tests are not just numbers to fix. They're clues pointing toward a cause, and recovers more reliably. And this leads us to the moment that scares people the most. What happens when the number is not just low, but dangerously low? When hemoglobin drops to levels like 5.3 grams DL, that's not about optimization anymore. Up to this point, everything we've discussed lives in the zone of understanding. Causes, patterns, signals. But there's a number that changes the conversation completely. A number that makes doctors sit up straight. A hemoglobin value around 5.3 GDL. When people hear this number, fear usually takes over. Is this fatal? Why am I still walking? How did it get this low without me collapsing? And those questions are valid. Because hemoglobin this low is not about optimization, nutrition, or lifestyle anymore. It's about immediate risk management. Here's the first thing to understand, and this surprises many people. Some individuals can function at extremely low hemoglobin levels. Not because it's safe, but because the body adapts slowly. Heart rate increases, blood circulation changes. Oxygen delivery is prioritized to vital organs. This is why someone like Nancy could still go to work even when her numbers were dangerously low. But adaptation has limits. Once those limits are crossed, the risk rises sharply. At HB levels around 5 to 6, the heart works overtime, oxygen delivery becomes unstable, even minor stress can trigger collapse. This is why doctors don't treat such numbers casually. Now here's something important. When hemoglobin is this low, doctors do not start by asking what supplements you took. They ask, are you stable right now? Is your heart coping? Is there active bleeding? Is oxygen delivery compromised? This is emergency thinking. Management decisions depend on symptoms, heart rate, blood pressure, underlying conditions, not just the number alone. This is also why two patients with the same HB value may be managed very differently. One may need immediate hospitalization. Another may be monitored closely with urgent intervention planned. And here's a critical safety point. This is not a situation for self-correction. No dietary change. No home remedy. No online protocol. At this level, treatment decisions are medical, often involving supervised iron therapy, close monitoring, and sometimes blood transfusion. Transfusions, by the way, are not given casually. Doctors weigh risks, benefits, speed of correction needed. The goal is not to normalize hemoglobin overnight. The goal is to prevent organ damage while addressing the underlying cause. This is where fear often clouds judgment. People ask, why didn't anyone catch this earlier? And the answer is usually uncomfortable, because symptoms were explained away, fatigue normalized, dizziness ignored, shortness of breath rationalized. Hemoglobin doesn't crash suddenly in most cases. It slides, and when it reaches emergency levels, it's not a surprise to the body, it's a breaking point. Now take a breath here, because this part matters. Low hemoglobin is serious, but panic helps no one. What helps is understanding when a number is dangerous, why doctors act the way they do, and why professional care is non-negotiable once stability is restored. The focus returns to something familiar, because emergency management stabilizes the patient. It does not solve the problem. And that brings us to the final piece of this video. After the crisis, after diagnosis, after stabilization, who should guide long-term care, a general physician or a hematologist? That decision matters more than most people realize. By now, one thing should be clear. Low hemoglobin is not a single problem with a single fixed dot, it's a trail of clues. Missing nutrients, silent blood loss, organ systems quietly interfering, and in severe cases, numbers that demand immediate attention. So once the cause is identified, once the emergency is controlled, once the reports finally start making sense, a practical question comes up: who should actually manage this long-term? A general physician or a hematologist? And the answer is not always obvious. For many people, a general physician is the right starting point. They are trained to interpret basic blood work, identify common deficiencies, manage mild to moderate anemia, coordinate care across systems. For cases like early iron deficiency, dietary gaps, or temporary drops after illness, AGP often does exactly what's needed. This is how Helen's situation unfolded. Her GP didn't jump to extreme conclusions, they looked at patterns. Identify B12 deficiency. Corrected the cause. No panic, just structured care. But there's a point where anemia stops being routine, and this is where a hematologist becomes essential. When hemoglobin keeps falling without a clear reason, when iron levels don't respond as expected, when multiple deficiencies overlap, when chronic disease complicates the picture, or when severe anemia enters the conversation. Hematologists specialize in blood disorders for a reason. They don't just look at numbers. They look at mechanisms. Bone marrow behavior, iron regulation, red cell lifespan, underlying pathology. This is often where cases like Nancy's finally make sense. Not because something was missed earlier, but because the problem was layered, and layers require expertise. Now here's something important to say clearly. Being referred to a hematologist does not mean something terrible is happening. It means the case deserves deeper attention. And deeper attention often leads to clearer answers and better outcomes. Now pause for a moment and zoom out. So far, we've walked through the full journey: why hemoglobin falls, how different causes look similar on the surface, why blood reports can be misleading, and when low numbers become urgent, but there's a quieter message underneath all of this. One that doesn't show up on lab reports. Low hemoglobin teaches us how easily the body adapts, and how easily we ignore it. Fatigue becomes normal. Shortness of breath becomes out of shape. Dizziness becomes stress. Until the body can't compensate anymore, and that's why awareness matters. Not fear, not obsession. Awareness. Knowing when symptoms deserve attention. Knowing when numbers deserve context. Knowing when to escalate care. This video wasn't created to turn viewers into doctors. It was created to make doctor visits clearer, calmer, and more productive. Because informed patients ask better questions, and better questions lead to better care. Now, as this series moves forward, the focus will shift. Understanding is only the first step. Next comes recovery, monitoring, and rebuilding strength safely. What happens after diagnosis? How treatment actually works over time. How progress is tracked and protected. And if you're just joining this series today, it's worth going back to Sunday's episode first. That's where we unpack why hemoglobin drops in the first place, and why so many people don't notice until it becomes serious. Starting there gives everything we discussed today the right context. That's the next part of the journey. If this video helped you connect the dots, if it answered questions you've been carrying quietly, or if it helped you understand someone else's struggle, stay with the series. And if you think this information could help someone you know, share it, because low hemoglobin is common. But confusion around it doesn't have to be. And remember, numbers matter, but understanding matters more.